Today's discussion is on cardiomyopathy. I've upgraded this lecture a little bit. So the major points is basically we're going to go into the definitions of what cardiomyopathies are. Then we're going to go into the three different kinds of cardiomyopathies that are in existence, which is dilated, hypertrophic, and restrictive cardiomyopathies. And so we're going into a little bit of detail of each one and what would be some things that you encounter in clinical. Basically, the definition of cardiomyopathy is a disease that's limited to the myocardium. And this is not disease that's usually due to ischemic heart disease or something like that. It's actually a cardiomyopathy that has an unknown etiology. Things that will be excluded from cardiomyopathies are things like hypertensive diseases, valvular diseases that lead to different forms of cardiomyopathy, and coronary artery disease. Now, this sort of kind of mixed up in a way, but cardiomyopathy has really been for many textbooks, they included it as part of that, but now the exclusion has been pulled away from those, which are those three things. So when we talk about valvular abnormalities, you're really not talking about cardiomyopathies. So and we call them specifically the valvular problems because those are correctable phenomena. Cardiomyopathies are very difficult to correct. About a third of them get better after the initial presentation. A third of them die, and a third eventually progress. So it's not something you really want to have as a diagnosis. Basically, the classification is based on the anatomic appearance, either as dilated, hypertrophic, or restrictive. So what you see is this person has a normal heart here in A, and you see the first one the most common one, which is dilated cardiomyopathies, okay, which the heart is actually enlarged. And then you have the hypertrophic kind, and then you have the restrictive kind. Restrictive, actually, the heart looks normal. The only way you know it's restrictive is you actually do a biopsy. And also the PA pressures will start to rise pretty quickly. What the restrictive disease process is basically you get infiltration and replacement of the myocyte with some other kind of tissue or some kind of other deposit, which we'll show you in a little bit. So let's go into the etiologies of dilated cardiomyopathy, which are the more common ones. I'd say, but if you have to look at these three diseases, which one is the most common? I'd say dilated. That counts for about 70% of the cardiomyopathies. 30% or 25% account for the hypertrophic, and maybe only a small percent, which is 5%, ends up being restrictive. The dilated cardiomyopathies a lot of times are idiopathic and sometimes have genetic disease processes such as mitochondrial disease processes where the mitochondria for some reason flames out and burns up, and it's not producing enough mitochondria, or the mitochondria not producing enough ATP, and then the myocardium itself dies as a consequence. Some of it's familial genetic diseases where you have some kind of abnormal chromosomal presentation of the myofibrils, where you get scarification of the heart. You may also get inflammatory ones. That's ones we get to see the most in the sense that these are the ones that you can reverse. Infectious ones, number one of these is virals. A lot of times you'll never know what the virus is that actually caused the heart problem. I remember when I was in the ICU in the intensive care unit, working here back in 95 through 97, I had, literally in a week and a half period of time, 3 young men in their age of 30 to 35. All of them were local cooks in town. All of them had been working with fish, and all of them came in with a congestive heart failure with an EFs of 5%. Dramatic. Okay, one of them had to go for cardiac transplant that I had to ship immediately because I couldn't get him any better. One of them actually reversed in a week and was back up to 35-50% EF in 6 months. And the second guy ended up progressing after going from 5%, went back to 25%, then began to diminish after that. So, and that pretty much follows a pattern. 1/3 get better, 1/3 get really, really bad, and 1/3 sort of stay in there and sort of progress along. Well, we never could figure out, actually had the CDC come down and try to find out what the heck was going on. They actually sequestered the fish that they were working on. They were from different restaurants, but each restaurant was working with fish. Somehow, something in the fish must have got into them, or they must have been exposed to something at the same time that was viral in etiology. We think it was Coxsackie virus, which is we'll show you in a minute. There's also non-infectious causes that cause inflammations of the heart, such as connective tissue disorders. Pericardium cardiomyopathy is something that I've seen quite a bit of, especially here in Naples. But you see it everywhere you work. And about maybe 2 to 3 cases a year will present with this. The reason that we pick up on it so quickly is because women usually have heart rates in the 110, 120 range, which is not normal. Okay? And you should immediately think, why is this woman going so fast? Her heart rate should be down in the 90s, not 120. Okay? So you've got to do an echo and find out what's going on. You can also have infiltrative diseases, such as sarcoidosis as well. Toxic agents can actually dilate the heart and cause damage, such as alcohol, so chronic alcohol injection. Chemotherapeutic agents specifically cause dilated cardiomyopathies because they actually damage the heart. The biggest culprit of that is doxorubicin. Doxorubicin is actually a red medication that we give for chemotherapy for many different kinds of cancers. Okay, and one of the things that you should check on before you start therapy is ultrasonography. Just establish a baseline for cardiac output, then you check out your echo every 3 to 6 months to make sure that the doxorubicin is not causing permanent damage. If you start seeing congestive heart failure, you start treating it early with ACE inhibitors, so hopefully you give a chance for the heart to recuperate. Metabolic-wise, you can also get cardiomyopathies due to elevated levels of TSH and low levels of T3, T4, so hypothyroidism. And chronic hypocalcemia and hypophosphatemia are known to also cause cardiomyopathy that's dilated in nature. And some muscular dystrophies and myotonic dystrophies may also lead to dilated cardiomyopathies. The viral cardiomyopathies usually present like this. They have these changes in their usually tongue, and that's what we saw in these 3 young men in their 30s. And you can actually see how viral infectious is. This is a kid that would suck their thumb, so what do they get? They got the virus inside their thumb as well. Okay? But that's a direct contamination, so that means that you can be exposed to it as well, so these people are infectious to you. Especially the actual the blisters. The blisters inside have a liquid, and that liquid is infested with these viruses. And you've got to be very careful not to expose yourself to these things. Okay? Coxsackie virus is an RNA virus. There's also rDNA viruses like adenovirus. Okay? What the viruses basically do is they basically steal the genetic train that the cell uses. They cut out a segment, or they actually become, if it's an RNA virus like Coxsackie virus, it actually uses what's called reverse transcriptase to reverse the RNA into a DNA, which then the DNA gets incorporated into the person's cellular DNA, and then it takes over the metabolic factory of the cell and produces more DNA more viral fragments, and eventually makes an encapsulated element, which then puts its RNA back in it and becomes highly infectious. So you can get these things from all sorts of different places. Most people have a certain degree of resistance to viruses, of course, but if it gets into your bloodstream, and it can be pretty lethal. The reason that most likely these chefs were getting it is that the people that they were giving the food to, it was cooked. So the virus is very sensitive to dehydration from cooking process, which kills the virus. But when they're working with either fish or whatever else they're working with, and they cut their fingers just a little bit, the virus can then penetrate into the bloodstream and cause a problem. Which is, if you worked with fish and/or the scales are pretty sharp, it cuts your skin pretty easily. So if you have a sick animal, you can get it infiltrated into your bloodstream pretty quick. Yeah, this other thing that I want you to be exposed to, which is most people don't know this, is Chagas disease. Chagas disease, especially in this area, you have to be worried about it because we have a lot of immigrant population coming from Central and South America. This is some place where I was growing up, and I learned about when I was a kid, like about 12. We were told never to sleep under thatched roofs, ever. We were never allowed to sleep under a thatched roof. And I never knew why until I became a doctor many years later. And that's because Chagas is a disease where it's a parasite that actually lives inside of a bug. It's what's called the retidiform bug, which I'll show you a picture of it next. What you see in this kid has periorbital edema, and you can see he's got blistering in his mouth. And actually, the way the Chagas disease gets into is the actual animal, the insect, lives inside the thatched roofs, and it defecates on you while you're sleeping. And if you have your mouth open, the defecated material gets into your mouth, and then you swallow it, and then it gets into your enteral system, eventually it gets into your bloodstream, and eventually you get this disease, okay, which is called trypanosome cruzi. Trypanosome cruzi will actually damage the myometrium and actually infect the tissue and cause damage, and eventually causes a massively dilated cardiomyopathy. These people take about 15 years to present, so usually in their peak of life, usually in their 20s, when they actually present with these problems, and they have EFs of 5 to 10%, and their heart is literally 10 times the normal size. In Brazil, it's an endemic problem, and of course, they don't have many transplant centers in Brazil, as you can imagine the cost of it. It's not a completely developed country just yet. So what they've done is they tried something radically new, which was what's called cardiac remodeling therapy. They actually took the heart and cut it and remodeled it and resutured it. What was really impressive is the ES went from 10% or 5% to 30 to 40%, and they thought they had cured the problem. They thought they were going to be able to do this. Unfortunately, within 8 to 9 months, 100% of their patients were dead from ventricular arrhythmias. Okay? So you can cut the myocardium, you may remodel it to improve your actual contractility function. The downside to it is you die from arrhythmias. Maybe if they had AICDs and they had more of the antiarrhythmic drugs, maybe they could survive, but it was unclear. But because the 100% mortality in 8 months, it was considered a failed attempt, and they've stopped really doing the therapy, although I think they should reconsider. The other thing you get with dilated cardiomyopathy is you get a marked enlargement of all 4 chambers. Hypertrophy may occur originally, but chamber enlargement is really the predominant effect that you see. And this is a normal myocardium here, the red. Okay, you can see here the in blue. That's all the scarification that's called myocyte degeneration, which is, you can actually see that what the ventricle tries to do is the myocytes would be maybe a third of this size. They hypertrophy to try to make up for this loss in functionality due to this fibrosing that's taking place inside the actual heart. Okay? So myocyte degeneration with irregular hypertrophy and atrophy of the myofibrils is the slide presentation that you would get when you do a biopsy. Of course, because you lose myocyte numbers, you're actually decreasing contractile function, which is why these people develop very low EFs of 5 to 10%. This is what a Chagas disease heart looks like. It looks like a big water bag. You can see the heart's very enlarged. You can see some vascular congestion in this individual. That's how we actually saw this person present. This is actually a woman. She presented with 5% EF, and she was from Guatemala, 4'2", something like that, and had Chagas disease. And she was 9 months pregnant. She survived the pregnancy, but unfortunately about 3 years later from when I heard, she passed away from this disease process because it pretty much doesn't stop. Very difficult to treat. What you see with myocyte injury, you see decreased contractility, eventual decrease in stroke volume. This leads to an increase in filling pressures, which increases pulmonary congestion and systemic congestion. So these people develop dyspnea, orthopnea, rales. The systemic congestion, they get JVD, hepatomegaly, and edema, of course, from right-sided heart failure. The left ventricle dilation eventually leads to an MR. A lot of these people develop severe MR, which is when we listened to this woman's heart, also we had a very severe MR, which is a grade 4 out of 6 holosystolic murmur that we heard on her, which was consistent with the echo, which had 4+ MR, which is very severe. You have decreased forward cardiac output because you're losing so much volume and the regurgitation as a process. And these people have EFs down to 5 to 10%, which causes severe weakness and fatigue. Medical treatment is very significant. Salt restriction. Diuretics are pretty important to decrease the actual preload volume. ACE inhibitors have been partly effective. Beta blockers have to be done just to make sure the patient's stable and can accept it. The other thing that's been done recently is we're using spironolactone, which is also a diuretic. Okay? Prevention and treatment of arrhythmias is really what causes most of the deaths. About 40% of deaths from dilated cardiomyopathies are from arrhythmias, usually VTAC or VFib. Okay? The other thing you'll see is that because the heart develops such a low ejection fraction, it develops an increased risk of developing atrial thrombosis. So you actually get atrial clots. So these people throw strokes, and they throw thromboembolic phenomena that goes over to the organ systems, so you can get GI infarcts and all sorts of bad things. The only real medical treatment of this is cardiac transplantation. The other agents have been used are usually too late by the time you have the diagnosis. So you can't really reverse the effects of the damage. Yes? Usually their heart is so large that they're already in the failure portion of the curve. So dilating, reducing the preload is actually a very effective treatment for these people. The problem is you can push it too hard and put them into low ejection failure as well, which is another concern. So, but most of the time these people come in with fluid overload syndromes. Yeah. Spironolactone is it's a different kind of diuretic. It's not like a loop diuretic. It's a potassium-sparing diuretic, and it works. Yeah, that's what I'm thinking of right now, how it works. Let me come back to you instead of BSing you. Okay. I'll be honest. I sometimes don't remember everything. So I'll look it up, back up, spironolactone. But it's one of those things that people have been using recently for it as well. The hypertrophic cardiomyopathies is the most common cardiac abnormality in young athletes that causes death from vigorous exercise. This is what we usually call IHSS. Sometimes I associate this when we do the valvular discussion, because when we go through that, we actually go into, it looks very similar to AS, so aortic stenosis. So when we'll go into that discussion of the valvular problems, we'll come back and talk about IHSS again. So hypertrophic cardiomyopathy is basically idiopathic hypertrophic subaortic stenosis, or IHSS. It tends to have a familial tendency, so people that present with this usually have a family member that's had sudden death. What you see with this is that you see septal enlargement at a higher rate than the ventricular walls, and that actually causes obstruction of the outflow tract. That's where it becomes significant. Some people don't have obstruction of the outflow tract, and that's not an issue then most of the time. They're not going to cause a sudden death. But the people that develop this kind of syndrome, like I've shown you here, where they have actually occlusion almost of the outflow tract by having the mitral valve too close in proximity to the septal wall, they may actually develop an acute syndrome where they look like they develop very elevated levels of afterload, which then limits your stroke volume and then puts the person into failure. And if you have it too severe, the heart will actually stop because the actual septal wall will touch the mitral valve and it won't be able to allow any flow to empty out of the left ventricle. So what you see in this situation under normal conditions is black pressure volume curve. These individuals, when they present to the clinic for physical examination, you are absolutely nothing. Their volume is full. Usually they're hydrated. You have absolutely no heart sounds differences. So you hear normally S1, S2, but you don't hear any murmurs, gallops, or bruits. So you're thinking everything's fine, this kid. Well, what happens is they go out and play in sports and they start getting dehydrated, so their preload begins to fall. And as the preload falls, the actual distance between the mitral valve wall and the septal wall begins to diminish. And eventually the preload becomes so diminished that all of a sudden there's a rapid increase in afterload, which is what you're seeing here. You're going from a low afterload to a high afterload. And the contractility is really not changing, but you'll see that the stroke volume becomes severely limited. Okay? But what makes the situation worse because of this idiopathic hypertrophic subaortic stenosis is that if you decrease the afterload rapidly or increase the contractility or increase the heart rate, which all those basically empty the heart more fully, then you have a higher tendency of developing complete obstruction of the outflow tract, and the person will actually have sudden death event. Okay? We'll talk about this later on in more detail, so I just want you to get a little bit of an idea of what a hypertrophic cardiomyopathy is. Treatment, beta blockers are usually a treatment of choice, calcium channel blockers as well. And antiarrhythmic medications, of course, are clearly important. You want to avoid going from a somal sinus rhythm into atrial flutter or atrial fib. The things that you want to avoid are things that are preload reducers. So nitrates and diuretics are really bad choices in these patients. So this is why, when people say to you cardiomyopathy, you've got to sort of ask, what kind of cardiomyopathy do you have? It's not all cardiomyopathies are treated the same. A dilated cardiomyopathy is actually can treat them with preload reducers, no problem. But a hypertrophic a cardiomyopathy, you don't want to give preload reducers. You get yourself in trouble really, really quick. Okay? So you got to know which one you're dealing with. Okay? The other thing that also digoxin, which is digitalis, the increased contractility, is a bad idea, which makes the situation worse as well. So the agent of drug that you would not want to use is the ephedrine. Ephedrine would be a bad choice. If you had to put this person to sleep and the blood pressure was falling, you should not give ephedrine. Ephedrine is an indirect acting agent, increases contractility and increases your heart rate. Bad, both situations. So what you should do is give neosynephrine, which increases afterload, which actually keeps the heart from emptying fully. So it keeps the outflow tract from decreasing its obstruction level. We'll show you pictures later on, like I said, when we talk about this in coexisting, about septal myomectomies. This is something that we actually did recently. Actually, I was surprised. I didn't think they would do it in a small little hospital like we have here, but our surgeons are actually very, very good, and I think they can do anything. So they actually did a myomectomy on a 29-year-old kid, and everything went really successful and went fine. Most of the time this is done in bigger centers, but the kid did well. Okay? What they do is they remove a portion of the septal wall and they cut it out. They do it from above. They don't go through the ventricle itself. They actually enter through the right atrium, okay? And then they open up the septal wall and they come in from above and then scoop out the area out. Okay? They actually cut it out. And then they put it back together again. The reason you don't want to go through the ventricular wall is because of the problem that we talked about, because of significant malignant arrhythmias that you may have. There's a new treatment called ethanol ablation where they actually are giving high-dose ethanol right next to the septal wall and actually ablates it, and it's decreasing the size. That's still a little experimental. Yes, somebody had a question? Yep. Yep. Yeah, you don't want to scoop out completely and then cause a ventricular septal defect. That's something you wouldn't want to do. The big danger, of course, is that as you're doing a myomectomy, is you knock out the left bundle or the right bundle. Usually it's the left bundle that you knock out first. Okay. The other thing that people are doing is they're putting implantable cardiac defibrillators in these kids. It doesn't really help most of the time because if you actually fibrillate, it's because you have no more forward cardiac output. You're in trouble. Doing CPR is not going to be really effective. What I'll talk to you about next time we talk about this, I'll tell you how to actually treat it possibly. At least it's theoretical. Nobody's ever done a study on it, but I think the only thing that you should do is just slightly different than normal CPR. So I'll talk about that another time. And one of the things that you want to make sure that you want to prevent in these people is prevent infective endocarditis. They're much more prone to it because of high velocity flow disturbances that you get in this disease. So these people should not have normal dental work without getting antibiotic prophylaxis. Okay? Now the next one, the last one we'll talk about is restrictive cardiomyopathy. The restrictive accounts for about 5% of all the cardiomyopathies. What you get in this is a abnormally rigid ventricle, and it's not necessarily thickened. So the ventricle looks fairly normal when you look at it under echo. When you actually look at it under echo, though, it appears to be a little bit more echogenic. And I've taken care of people that had amyloidosis of their heart, and when you look at the actual echo, it looks like it sparkles. It looks kind of strange when you look at it under TEE. It's kind of hard to explain to you unless you've seen the TEE a number of times. But the actual material is being replaced. The myocardium is actually being replaced by a deposited material, usually. Okay, that's what causes restrictive cardiomyopathy. In essence, you're replacing normal myometrium with basically scar. Okay, but it's micro scars. It's not like a big scar like from an infarct, like I showed you in the last slide in the last hour. Instead, you get this like diffuse pattern inside the ventricle itself. So here's what you see on the slide. This is the myocardial cells. It looks pretty normal, okay? But then you see this stuff under blue light, okay, or dark field, and you see this infiltration, and that's the actual deposits of amyloid, okay? What you get eventually is you get impaired diastolic filling because the ventricle can't dilate, so you get a high LV-EDP, so you get a decrease in compliance. So it almost appears that the person's hypertrophying, but they're really not. You get fibrosing, scarring of the endomyocardium, and infiltration by this abnormal substance. So what do you have? You have several kinds. You have the non-infiltrative type, which is idiopathic in nature, which means you don't really know what the cause is, or scleroderma, which is my one that I know a lot about because I used to take care of a lot of patients here in Naples that have scleroderma, at least in the intensive care unit, because usually that's where they ended up, when they got sick at the end. And scleroderma is basically a disease process where you get infiltration of the small vessels by this material, usually it's collagen, and you get infarcting of these small blood vessels. Okay? And what you'll see is the skin will become translucent. Okay? It looks almost pearly. It almost looks like a china doll, the skin color. So it becomes intensely white. The intense white is because you have no more blood flow going to the skin. So you'll get scarring, and if you look at the fingernails, you'll start losing the fingernails, and the actual skin will get very, very tight in appearance. You'll get tightness in the face, and the actual nose will become more angular, and the person has what they describe as more of a mouse face, which means that their face narrows down, and their nose becomes very sharp, and they get this kind of smaller mouth. They also will develop scleroderma in the heart. It'll attack the small vessels in the heart, and we'll get collagen deposition around the small vessels, and you start getting microinfarcts as a consequence, and you get fibrosing all over the heart. That's the non-infiltrative. The reason being is you're not seeing infiltration in the myocardium itself. It's seeing infiltration around the blood vessels themselves. It's a little bit different process. The infiltrative is actually a process where you get abnormal protein deposition into the myometrium itself. So when you actually look at the slide of the myometrium, you actually will see infiltrative material in there, okay? And that's amyloid and sarcoidosis, okay? Amyloid, I'll show you a picture of that in a minute. You see with Congo red, and it's kind of obvious. Storage diseases are like hemochromatosis or glycogen storage diseases will affect, it will cause deposition effects on the actual mitochondria, and also the endoplasmic reticulum will become damaged, and as a consequence, it affects calcium release. And then you also may have endomyocardial diseases, such as endomyocardial fibrosis, hypereosinophilic syndrome, metastatic tumors, or radiation therapy. I've seen radiation therapy really do devastating effects to the heart, so it's something you have to be careful with as well. These are very rare, thank goodness, most of the time. The ones that you have to really consider pathognomonic for restrictive cardiomyopathy is considered amyloidosis. So what is amyloidosis? Amyloid is a systemic disease. It leads to an insoluble misfolding of the amyloid fibrils to be deposited within the tissue. And you can see on this slide, they've done this with Congo red. They've got, here's a normal myocyte over here, part of it, and you can see the amyloids deposited heavily inside the cell. So this is what actually infiltrates inside the tissue and inside the cells. It's called amyloid deposits. Primary amyloidosis could be from a cancer that originates from the bone marrow called multiple myeloma. It's an IgA due to plasma cell tumor. This can be seen in the elderly population. Chemotherapy treats this and reverses the effect, so that's good. Secondary amyloidosis is a little bit more difficult to treat because we don't know the actual etiology of it. And you get what's called AA amyloid, or chronic inflammatory syndromes will lead to this secondary amyloidosis. Some people actually have hereditary amyloidosis, which is their parents have had it and then they pass it on to their children. And the more common of all of them is the senile amyloidosis, which is just from aging. We think it's some kind of DNA breakdown where the amyloid doesn't fold properly and now becomes misfolded. Amyloid is a kind of protein, basically. What you see is reduced compliance of the ventricles, and it affects both ventricles, tends to be equally. It causes an upward shift on the preload curve, which means it decreases the ventricular compliance. The two major consequences will be elevated systemic and pulmonic venous pressures with signs of right and left vascular congestion. You get reduced ventricular cavity with decreased stroke volume and cardiac output as a consequence. So this is almost like a backward flow failure kind of problem. Okay? The ventricle gets smaller and smaller, and even though the pressures are higher to get the volume in, you're still not getting enough volume. It's almost like a diastolic dysfunction. And what most of these people die from is arrhythmias. They go into basically AFib, and if you go into AFib, these individuals require normal atrial kick, which accounts for 40 to 50% of their preload volume. Imagine that. Normally it's 10 to 15% to up to 20% max. These people almost go at 40% of their preloads depending on atrial contraction. So if these people go into atrial flood or atrial fib, they go into failure immediately. I mean, it's pretty bad. So one of the things that you've got to be very, very aggressive is treating arrhythmias in these individuals. Unfortunately, restrictive cardiomyopathies have very poor prognosis, which a good thing is that they're rare. The bad thing is that if you do have it, then you've got a very poor prognosis. They've been trying some new things, such as phlebotomy. Phlebotomy is more for the copper, that accumulates in your bloodstream that can occur. That'll treat that. Inculation therapy as well. Some people are actually using, what's it called? Not phlebotomy, but it's not dialysis either. They actually put you through a system to filter your blood. I can't remember right now. Plasmapheresis, I'm thinking. Yeah. So you take plasmapheresis and you take the amyloid out of the plasma and decrease the actual depositional effects. But that means you get plasmapheresis pretty much for the rest of your life, which is it'll slow down the progression, but it's not going to eliminate the disease completely. Salt restriction. Be very careful using diuretics, because this is one of those that if you drop the preload too much, you would put them into failure very quickly. So this is very cautious tale about using diuretics in these individuals. And vasodilators are really not that helpful at all as well in these treatments, because you're not really you're not trying to reverse hypertrophy or anything. This is the depositional disease. And critically, most important is to maintain a normal sinus rhythm. Okay, so if you ever take somebody with restrictive cardiomyopathy to sleep, you got to keep them in sinus rhythm. If you don't, it's going to be over with real quick. Okay, and once you get in trouble with these people, it's very hard to get yourself out of it. There's nowhere to play. Okay, we had one guy like this arrest on us in the operating room table, and what actually got him back was open heart massage. So we actually did that, and I got him back. But pretty much everything else didn't work. Epinephrine was like, pfft. And the surgeon just cut the chest open, grabbed the heart, squeezed it, got the heart starting again, then we were back on okay. So it was just one of the things you don't want to be there if you can avoid it, but if you do, you can go to that extent in the operating room. Okay? You have the person asleep already, they're intubated. Why not? Give them a chance. If not, some patients, when they go into the operating room now, the last few years, about the last 10 years ago, we changed the patient's rights. Before that, patients were not allowed to have any say as to what we would do once we put them in the operating room. We pretty much rescinded all your rights once you went to the operating room, in the sense of what we can actually do to resuscitate you. And we found out that a lot of people didn't like that idea. Some people said, you know what, I'm already asleep. If I pass away, you know what, just let me go. So we actually had to give them a choice. So now when you go to clinical, you'll see a sheet. And especially high-risk patients, I talk to them ahead of time, because a lot of them are DNR. And it's not appropriate just to say, well, you're going to our surgery, so we're going to rescind your DNR. Some of these people will say, you know what, if my heart stops, just let me go. And they're okay with it. So you sort of talk to them about it, and you have usually 3 choices on our sheet. One of them says, we rescind your DNR, and we'll basically do everything that we can. The other one says that we're not going to rescind your DNR at all, which means that if your heart stops, we don't do anything at all. And then the middle one says, if you do have a heart stoppage, and you'll give us a right to decide for you if we should go on or not. If we think it's reversible, we'll treat it, but we're not going to go through extraordinary measures. Okay, so sort of have those discussions with your patients ahead of time. It makes them feel more secure, even though they're tough discussions, because the way you approach it. I'm always trying to tell people, look, let me be able to make the decision if I can reverse you or not. But some people, I've had people tell me, you know what, my heart stops, I don't want you doing anything at all. Like, okay, all right. And I respect their opinion. Okay? I usually try not to get them there if I can avoid it. That doesn't mean you don't give ephedrine. Okay? DNR does not become DNT, which is do not treat. Okay? DNR means do not resuscitate, which means the heart stopped at that point. So don't get yourself into a position that's not good either. All right, that's it for today. Okay, we'll start Next week after the test, there'll be 2 hours of lecture after that. Okay? So good luck next week. You have any questions about anything? Yes?